Admission was ordered due to urosepsis, but there was no inpatient bed available. She was put in a holding bed awaiting transfer to the floor, which was a standard emergency department surface. There was no emergency department skin exam documented. There was no claim or documentation of turning and repositioning. The head of bed was elevated roughly 30 degrees. She had a meal while she was in the department. She was transferred to the floor at 23:15 hours or 11:15 p.m., 9+ hours after she arrived in the emergency department. So skin examination at 1 o'clock the following morning documents blanchable erythema over the sacrococcygeal area. Braden score was 11. Skin protocol was initiated to include turning and repositioning every 2 hours, and that turning and repositioning was sporadically documented over the next week. Day 4, purple discoloration beginning on the sacrococcygeal area, evolving to skin slippage and an unstageable eschar by day 12. So, oops, this was a known high-risk patient due to her long-standing multiple sclerosis and mobility challenges. 9 hours and 15 minutes of essentially unrelieved pressure in the emergency department with no turning and repositioning of this lady who was unable to turn and reposition herself. She had a relatively high-risk Braden score on arrival in the emergency department. And so forget about the failure to follow protocol. This was a failure to do the right thing for the patient. So we talk about increasing costs of hospitalizations due to pressure injury. We talk about the medical legal environment, but the bottom line here is that we need to provide the proper and thoughtful care for the patients who are at risk.